Hello everyone, my name is Tim McCarthy, and today I'm going to be talking about psilocybin and its hallucinogenic effects. So for a bit of background, both psilocin, which is active, and the prodrug psilocybin, which is inactive, are found in over 200 mushroom species within the Basidiomycota division in the fungi kingdom. And the majority of mushroom species containing psilocybin are of the psilocybe genus, and it contains about 100 of them. It can be synthetically manufactured using organic chemical synthesis methods, and the first research and discovery papers were published in 1958 by Hoffman. It can also be cultivated through mushrooms or genetically modified E. coli bacteria and yeast. It's got disputed use in ancient civilizations. There's some evidence that suggests pre-Columbian native Mayans and Americans used hallucinogenic mushrooms during religious ceremonies, but otherwise this was rare for the rest of the world, with most of the claims being exaggerated or misinterpreted. So there's the Amanita muscaria mushroom in the Old World, mainly Siberia, where it does not contain psilocybin, but other chemicals used for hallucinogenic purposes. And then now there's new evidence of an ancient Algerian cult about 6,000 years ago that used these mushrooms for those purposes. We have a picture of the mushroom distributed worldwide. This is the P. mexicana, which is the mushroom that psilocybin was first extracted from. And then this is the previous pathway that we thought led to the production of psilocybin and psilocin. Now we know it's different with the phosphorylation and decarboxylation step happening in different orders than we thought it did here. And then here's a bit of chemistry. So from left to right, we have psilocybin, psilocin, and serotonin. You can see that they're similar. At room temperature, psilocybin exists as a white crystalline solid, soluble in polar solvents like water, ethanol, methanol, but insoluble in non-polar solvents, so like chloroform and ethers. It's got a melting point of 220 degrees Celsius, and it exists as a Zwitter ion. And it rapidly oxidizes when exposed to light, and that's important in research settings. It is a derivative of the amino acid tryptophan, and it used to be a compound that acted as an antioxidant in pre-multicellular life. And then some structural analogs of psilocybin are serotonin, DMT, the many DMT analogs, and then ethosibin. As I mentioned before, psilocybin is the inactive prodrug of psilocin, and that's the one responsible for the effects. Structurally, it's very similar to serotonin, and it's a partial agonist to its 5-HT2A receptor. Most of the other serotonin receptors, just not 5-HT3. It shows little affinity for dopamine receptors, unlike others like LSD. Selective 5-HT2A antagonists, like the medication risperidone, prevent psilocin from binding and activating these receptors. And receptor binding in the medial prefrontal cortex releases glutamate. There's a significant relationship between receptor occupancy and hallucinogenic effects. So the more receptors that are occupied, the stronger these effects. And then region-dependent glutamate concentrations are possibly related to ego dissolution, so like ego death. Pharmacokinetics. Psilocybin has poor oral bioavailability. It's about 20% as effective as IV administration, but the first pass effect of oral administration is crucial to its bioavailability and effect because psilocybin must be metabolized to psilocin before it can produce these effects. Psilocin is detectable in blood in 20 to 40 minutes, and it's got a peak concentration in the blood after around 2 hours. Psilocybin is hydrophilic, meaning it can't cross the blood-brain barrier easily, but psilocin can because it's lipophilic. And virtually all the psilocybin ingested is dephosphorylated during the first pass, so there's no psilocybin content ever found in the blood. It's always psilocin, largely because the acidic environment in the stomach and metabolization in tissues. It's mostly eliminated, so around 80% in the urine, and then the remaining is in bile, and it has a half-life of between 2 and 4 hours if taken orally, and then around 1 if taken via IV. It produces a variety of effects, including physical, psychological, perceptual, and interpersonal. Some common physical effects are pupil dilation, an increase or decrease in either the heart rate, blood pressure, and stretch reflex. Then there's some nausea, but studies have shown that this is from the mushroom itself, not the psilocybin. Then also tremors and dysmetria, which is the inability to properly direct or limit motions. And when taken over 21 days, it had no measurable effect on the electrolyte levels, blood sugar levels, or liver toxicity tests. Long-term effects include cardiac fibrosis and cardiac toxicity, although this is more applying to chronic psychedelic microdosing, so like small ones every day, rather than single high doses or spaced out doses, so like every couple weeks or months. It produces a wide range of emotional effects like disorientation, lethargy, giddiness, euphoria, and depression. And when given a high dose, 1/3 of participants in the study experienced anxiety and paranoia, but when given a moderate dose, negative experiences were rare. And when given a low dose, more participants reported hallucinogenic effects. The big one are perceptual effects. So you could experience closed eye hallucinations, so the perception of multicolored geometric shapes in vivid imaginative sequences, or open eye hallucinations, which are common and detailed but rarely confused with reality. Participants in a study also had the inability to gauge time intervals beyond 2 seconds, and then when asked to keep a beat, their tapping rate slowed down. These results are consistent with drug activity in the prefrontal cortex, so we know that the activity of the drug in these areas are producing these effects. So for interpersonal effects, they're highly variable based on the setting and mindset of the person taking it and also the group size that they're in. Groups smaller than 8 felt that the environment was more supportive, while groups larger than 8 felt that it was less supportive. And supportive settings significantly decrease the likelihood of adverse reactions. And in group settings, recent Western clinical practices have started trying therapies where groups of patients participate together. Beliefs associating psilocybin with religious healing and introspective connotations, along with traditional experiences. Those are done in group settings. And then anthropological studies have linked Native American groups to psychedelic use for these purposes. This is a study that I found was interesting. So brain imaging techniques were used to display the effect of psilocin on different brain regions. Tolerance rapidly increases, especially from other psychedelics, so there's cross tolerance, and the 5-HT2A receptor downregulates. But this is only when using psychedelics. Non-psychedelics do not experience this. It is Schedule 1. It is high abuse potential, no currently accepted medical use, but addiction is likely more psychological than physical. And then that is it. Here's my bibliography, and thank you so much for watching.